There are things we can do and things we can't. Sometimes we need just a little bit of help, and sometimes quite a lot. Whatever your need as a person living with a disability, MyCare Channel can put you in touch with the people who can assist. You don't need to navigate the process alone. Just call us on 1300 461 300 or visit mycarechannel.org.au and we'll start you on the journey of a life lived to the best of your ability.
The draft report from the Disability Royal Commission into the vaccination rollout for people with disabilities said that the government rollout was seriously deficient. Today I'm joined with Catherine McAlpine, CEO of Inclusion Australia, and Stephanie Gotlib, CEO of VALID, the Victorian Advocacy League for Individuals with Disability. Thanks for joining us today, ladies. Now, let's talk about the proposed government rollout for the COVID-19 vaccine and the plan, and how that plan became very different in theory than in practice. So let's pass over to you, Catherine. What was the government's plan?
When the pandemic hit and the government were looking at the at-risk populations, they identified people who were age 70 and over as priorities, and they didn't prioritise people with disability. So for the disability advocacy organisations, we were up against it right from the start in terms of trying to make sure that there was a plan for people with disability. So there was a mad, then they put together an advisory committee, and then there was a mad scramble to get all that done. And so they did that. And so then one of the things that we talked about a lot was planning for vaccination. Now, in amongst all of that, the evidence from overseas started to arrive, and what we saw there was that the at-risk group was exactly the group that the government had identified, the over 70s. The second biggest group at a pro rata basis who have had serious outcomes from COVID are people with an intellectual disability. So we sent that off to the government and said, it's really important that people with an intellectual disability in particular are also prioritised. And so that's in many ways who was in 1A. So 1A were people in residential aged care and residential disability care. So what that acknowledged was that there were two risk factors. One is that the fact that people are in a congregate setting, because this is a very highly infectious disease, that you're at greater risk of having it, greater risk of transmission. You've got more people in your life. They're possibly giving you personal care. So therefore, there's a much greater risk there. And then for both elderly Australians and also people with intellectual disability, there's often an underlying medical condition that might be make you more at risk. So for example, people with Down syndrome are much more at risk of adverse outcomes from COVID than say someone with another sensory disability or something like that. You know, it's quite different. So in those meetings, we were told that that meant that they were people in 1A, and then in 1B there was a lot of people with disability, and that included, and we did quite a lot of advocacy to make sure that all people with intellectual disability were included in 1B, which eventually they were. And we had meeting after meeting where we were pushing and pushing and pushing to find out what happened, and they kept giving us combined data. So they'd say, this is how many vaccinations have happened in aged care and disability care. And it took us a few weeks to realise, and then we started asking for the disaggregated data, and it didn't come. And of course, none of us found out until we saw what had happened at Senate estimates. Yeah, that in fact there'd be a prioritisation. And to be fair, well, not to be fair, but to be realistic, what health discovered, which they didn't really understand, is that aged care, you're looking at facilities often with more than 100 people. In group homes, you're looking at situations where there are 5 people. And so the logistics, and because the Pfizer vaccine in particular has got to be kept at very low temperatures, there are there are supply chain issues that need to be resolved. We'd also note that the government has spent millions and billions of dollars on the wellbeing of Australians in terms of the pandemic, and that that they had the resources. They put aside the resources, and it was identified really early on, and they could have done something about it. And so it was incredibly disappointing that that's where we ended up.
So as Catherine has said, the rollout was incredibly disappointing, and following this it was announced that there would be a Disability Royal Commission into the vaccine rollout. What does that draft report say, Stephanie?
Look, the draft report was released a couple of weeks ago, and what it revealed, it spoke about a number of things. One was the real concern that people with disability had actually been not prioritised in the initial rollout of the vaccination as they should have been. And so while that is understandable that older people needed to get their vaccine ASAP, it also meant that it's meant that many people with disability actually haven't been vaccinated as yet. So that was one of the really startling findings. One of the other findings was that actually there was no communication around that to people with disability or their representative organisations. So it was a double whammy in many ways. It was a deprioritising, and there was no communication. So we couldn't all say, hey, what about people with intellectual disability or people with disability more generally? So that was incredibly concerning, yeah.
That seems incredibly frustrating. Why was this reprioritisation not made aware to you or to the community?
I think there was a confluence. I think there was a confluence of events. So what happened was we saw outbreaks. So over the time of the pandemic, we saw some outbreaks in aged care, and we saw a lot of deaths in aged care. And so clearly that focused their attention. Look, and there are some complexities about what happened in disability care in terms of how people would get safe, people were kept safe. Because on the one hand, the government and providers get to say they get to say they kept a lot of people with disability safe, because they did, because we didn't get any, we did get some individual breakouts, but we didn't get any sort of mass breakouts, across multiple settings. But on the other hand, they locked people in rooms and did some other, things that were not very well good for people's mental health and health in other ways. So that was complex. So one of the things, I think the government had that problem. Secondly, at a government level, like at a political level, as far as I can remember, the Prime Minister never talked about people with disability in all of that early period, and they certainly didn't talk about people with intellectual disability. So people with disability felt like they were forgotten, and they felt like they were not important because they were never mentioned in those important briefings that they were there. And you will have seen in more recent times, particularly at state level, that, and some premiers have done more of this than others, they've talked about what their plans are to support people with disability more specifically. So I would also say that the government had a bit of a blind spot about people with disability and were very, very slow in taking targeted action.
But surely this is something that could have and should have been communicated.
Absolutely, and that's what I was talking about before in terms of, people with disability not only were deprioritised, but also were denied the right to be informed, consulted, which is a right as well. But it's really important that we say this is not okay because of all the reasons I've talked about. There's what we've seen for those living in disability residential services care is that the risk is just as equal to people living in aged residential care, So there's an abundance of evidence that shows that people with disability absolutely need to be a priority for vaccination.
Do you think there is an added barrier in your community because some people can't attend, say, mass vaccination hubs, for example, or they need the vaccine to come to them in their homes?
Oh, it's even more complicated than that. So there are two things here. The first thing is that people in group homes were Group 1A.
Yeah.
And what happened in Group 1A is the Commonwealth Government was responsible for the delivery of vaccines in Group 1A. And one of the definitions of Group 1A was these are the people who need the vaccine to go to them. So the whole premise of 1A from the very beginning of the plan was that the vaccine would go to the people. So that's particularly people in group homes. It's people in congregate settings. So that's number one, that the Commonwealth Government had that responsibility, and they knew from the get-go that they would be going to people's homes, where in this case, people's homes were group homes.
Mm.
In Group 1B, state governments were responsible for the rollout, and that's where we were looking more at mass vaccination hubs. And so they're people with intellectual disability who live with their families or live in other settings, but not in group homes. So both are true at the same time. So the Commonwealth Government was responsible for making sure that people got the vaccine in their house, in their homes. Where we get to a whole lot of complexity is around consent, is that because of the rush, there was not necessarily good support for decision making put in for people to make their own decisions. We've had a lot of confusion about people understanding who actually is able to make decisions, because in fact, it's not necessarily the case that a family member of an adult with an intellectual disability actually gets to make a substitute decision for them. That people with intellectual disability can be greatly affected by the misinformation that's in the community, and that there's a lot of people with intellectual disability or multiple disabilities who have high support needs when it comes to getting a vaccine. And remembering, as I said earlier, that a lot of people with intellectual disability have an underlying condition. And one of the things that happens when you have an underlying condition is that you interface with the health system more often. You're more likely to have had more needles, had more blood tests, had more invasive procedures. You're more likely to have become more sensitized to it. You're more likely to have experienced some trauma, so you end up with it being more complex. And so that's why I would acknowledge from the get-go that taking it to group homes was always going to be complex, because you needed time for people to get support for decision making. You needed time to sort out consent. You needed time to put in a plan for people who had more complex support needs. You needed to allow for people changing their mind at the last minute. We're not saying it's not, in many situations, that it's not complex, but we would also say that an Australian government has responsibilities to all its citizens. And it does seem that, it's easier to do a lot of citizens in a mass vaccination clinic. It's hard to go out to remote communities. It's hard to go out to communities of people where English is not their first language. It's hard to go out to communities, anyone with complex communication support or complex health support needs or whatever. It is harder. And it just seems the government, they wanted the numbers, they went for the obvious people, and they've left and more than one at-risk community behind.
So how do we make sure that something like this does not happen again?
One of the things is that, and I do, to be fair, I think at a bureaucracy level, I think health is learning this lesson very fast, is your emergency planning has to include people with disability. And so one of the things you'll hear in the disability community, and it's come up in the Royal Commission as well, is that disaster planning often doesn't include people with disability. So in terms of the bushfires that we'd had just before the pandemic, there'd been a lot of problems for people with disability then as well. So not enough emergency planning takes into account people with disability. Certainly whatever pandemic planning the government had done didn't take into account enough people with disability, didn't think about some of the complexities. The Department of Health, for example, did not have communication systems in place where they routinely put out Easy Read. Now, if you know that you're going to have to produce Easy Read, you can put things in place. So if you look at a thing like the Independent Advisory Council of the NDIA, so that's a group of people with disability and families who advise the NDIA. They have formal meetings, and they put out formal communiques from their meetings every time they have a meeting. They routinely produce the Easy Read 7 days later, because you're able to produce Easy Read more quickly if you're anticipating that's going to come.
Right.
So if you have mechanisms where you say, every time we do a thing and there's an important announcement, we make sure we do this thing. So which we also said in the Royal Commission, some of the messaging was straightforward. So some of the social distancing messaging, and even messages that say vaccinating people in group homes is really complex. It might take us a couple of weeks to get the message to you. Like, then we'd know. And so having sort of really plain language messages that go, this is what we need to know. These are the high. You can do things in plain language.
Yeah.
And you can do things easy read. Easy read itself is comprised of two main components, and that is very straightforward language supported by images.
Yeah.
And the very straightforward language needs to be one idea per sentence, needs to be short sentences, needs to be the main theme, all the rest of it. There's some sort of, criteria around easy read. It is possible to produce the easy read language more quickly than it is to produce a whole easy read material. And one of the things that you hear from First Nations communities and core communities, or the organisations that represent them, is that the information that needs to be translated is the easy read information. Because for a lot of people they might not be overly literate in their first language anyway. It might be more of an oral language than a written language.
Right.
And so the best thing to do, so increasingly what we're realising is that a lot of things that get translated should be translated from the easy read text, not from the original text, which means the market and the necessity for easy read communications is very high. So it's, we would like to see governments increasing their easy read capacity, their capacity to do a little bit more in-house in terms of emergency messaging. We acknowledge that there will be some emergency time limited messaging that won't be able to be tested with people with intellectual disability, so needs skilled people writing first drafts of things.
Sure.
And then you need to have a system that can kick into gear to make sure the information that's needed. So then you can get Auslan interpreters, audio descriptions, Braille and easy read, all the specialist sort of accessible formats that you can get all of those up and running fairly quickly.
Stephanie, would you agree? Do you think that it has something to do around the fact that you don't feel that your community was listened to?
Absolutely. I think a really critical part of this was not speaking to people with disability and their representative organisations. There's a very strong and strong network, informed network of advocates of disabled persons organisations, of disability representative organisations that should be consulted on an ongoing basis. There's formal committees that have been established specifically around the COVID vaccination and COVID response more generally. They need to be consulted and kept up to date with any particularly life-changing decisions that are made regarding people with disability. That is absolutely essential.
Thanks for your time today, ladies. To learn more about the Disability Royal Commission, you can head to the Disability Royal Commission website or just visit us at www.mycarechannel.org.au. Thanks for joining us, and as always, if you have any questions, queries or concerns, give us a call on 1300 46 1300.
Do you sometimes feel you need help, but that finding the right help is just too hard? At MyCare Channel, we'll make it easier. We'll cut through the maze of information and help you make an informed decision about help for yourself or your loved one. We offer free information in English and progressively in 26 other languages. So call us on 1300 46 1300, subscribe to our channel and follow us on our socials. And we'll connect you with the support you need to live well and age well.